My thinking is that until we get to a point where the demand side from the provider community or health systems, et cetera, pushes the vendors to the direction where they know they have to go. There's nobody here that's going to disagree with the fact that interoperability is both good and important, and that we depend on them for making those things happen. The problem is that we don't put our money where our mouth is. So if we can see within the next 12, 18, 24 months that those of us who buy systems, whether it's large health systems or small physician practices, buy only those systems that act in the way that we want them to act, I don't think a lot is going to change. How do we educate the buyers to ask for the right things? Because if the buyers are willing to put money into a particular direction, vendors will absolutely jump over huge walls to make that happen. But until they do, it's kind of weird for us to say that we want the vendors to do, quote, the right thing, when we haven't actually put the right thing into an RFP, into a procurement document, or made the specific request. So what I'm seeing, though, the good news is that we're seeing that, especially the larger health systems, as they normally do, are starting to drive that demand. So if we go back to simple economics and say, the supply of interoperable systems is directly related to the demand through actual cash payments. If that statement is true, and I think that it is, that's why we are where we are today.
I'm confused about why a buyer. There are three things going on. One is that buyers are buying large-scale enterprise IT implementations, which take a long time, and the two most successful companies in this business, one for the medium-sized and small hospitals, one for the big hospitals, basically tell the buyer what to buy. Number two, the buyers themselves, okay, eventually they're going to be paid in a different way, but Mark Berkeley, and he showed the chart this morning, we're still at 90% fee-for-service, fill the bed. So where is the demand going to come from to change the buyers without some form of aggressive change in regulation? Now it's going to come eventually, it's going to happen in different places, but 18 to 24 months, if we're relying on those two things to happen, it's not going to happen. We have to push that some other way. And I'm still struggling to see what it is unless you can aggressively push meaningful use, which is why I have more optimism for that than a big system-wide change.
I would say if you want to think about policy levers and take a deeper regulatory approach to this, take a look at what the bipartisan efforts that are underway now tied along with the SGR fix, where they're talking about taking meaningful use and PQRS and alternative payment models and the value-based payment system, all these different CMS programs, and putting them into what's called MIPS. It's Merit Incentive Program. And I think that having everything under one house like that, it makes a lot more sense and will be much more effective at using that as a policy vehicle for driving change. The last thing we need in healthcare is more acronyms, more alliances, more consortiums, more initiatives that are driven on the supply side, because then we're talking to each other in an echo chamber.
And what I would say is, working with clinicians, I haven't met a single clinician who didn't want to talk to their colleagues about the care of a patient, period. And yet at the same time, health systems are not connecting to each other at the pace at which you would expect. And I think a lot of that is just it's easier to not. So, I think there's a real hunger out there amongst providers to connect with each other, and I think it's going to happen as soon as the tools are available. So again, I guess it's make the right thing to do, the easy thing to do, and the docs will flock to this stuff. And once they do, they'll start talking to their patients, and their patients will say, "You mean I can get my data?" I think that a lot of that puts it in motion. So the idea of, as Brian said, start this year with provider to provider, look for the halo effect of provider to patient. I think we're going to see some great things. I think a year from now, if you have this panel again, it'll be more of a success story and less of a someday soon story.